In ortho hand, we're going to go through some of the lower yield diseases, but the still diseases you can easily recognize on an exam that make it really easy to get that final point. Of these diseases, the one to pay attention to is carpal tunnel, and the other ones we'll mention so that you've heard them, so that you can identify them when you see them on the test. Let's start off with carpal tunnel because it's the most important of the diseases in this lecture. Carpal tunnel syndrome is caused by compression of the median nerve. And this happens as the median nerve runs through the carpal tunnel. And it's effectively an inflammatory disorder. And if you recall your anatomy, the carpal tunnel, the median nerve runs through the carpal tunnel into the anterior aspect of the hand. It innervates the first 3 digits. So median nerve is going to control sensation and motor of the first 3 digits. The ulnar nerve, next to the ulna, is going to control digits 4 and 5, same thing, sensation and motor. The back of the hand is by the radial nerve. If you've got compression of the median nerve in the carpal tunnel, you're going to have impacted the first 3 digits. And the patient usually complains of pain. And pain will progress to paresthesias. And if you let it go on long enough, paresthesias end up with paralysis. This happens in the first 3 digits. And you can elicit this with physical exam maneuvers. If you put the person into purposeful flexion, you will make the symptoms worse. This is Phelan sign. Phelan sign where you have them put the back of their hands together and really flex their wrists. If you tap on the median nerve, that makes it worse. This is Tinnell sign. And a late sign of the disease. If you allow this to go on long enough and you have paresthesias and paralysis, eventually you will develop thenar atrophy. You generally want to intervene before that happens. The type of patient who's going to get this disease is going to be someone who sits at a desk all day, keeping their wrists in flexion. It is someone who uses their hands a lot. But also pay attention for the people who get it more often, those with hypothyroidism and diabetes. The diagnosis is made with an EMG. You're going to see decreased conduction through the median nerve. But you generally don't have to do that test. You only do an EMG before surgery. And the way you treat this person is not with surgery. First is splinting and NSAIDs. Give anti-inflammatories and keep them out of flexion. The second is going to be intra-articular steroids. And only after all of these have failed do you progress to surgery. At which point you'll do the EMG before you take them to the operating room. And what you have to realize is that carpal tunnel syndrome could be the presenting symptom of rheumatoid arthritis. So if you see somebody who is the right age range and may have other symptoms, think about RA when you see carpal tunnel. Okay, let's transition and talk about the fingers. There's 3 you have to know about. Jersey finger, mallet finger, and trigger finger. This is ripe for a question because they're so distinct from each other, but are all very similar in the fact that they have some sort of flexion or extension of the hand. Now, jersey finger is not called jersey finger because someone in New Jersey had it. It's because if you're playing sports and you grab someone by the jersey and they pull away from you really hard, your hand rips open. And in ripping open, you tear the flexor tendon. If you tear the flexor tendon, what do you think the patient can't do? They can't flex that finger. They can extend no problem, but when they make a fist, that finger affected stays up. Passively moved into position, no problem. They open their hand again and try to close it, the finger remains extended. The diagnosis is clinical. And as much as you'll see in orthopedics, the treatment is going to be the standard. And I'm writing that to save space. splinting and NSAIDs, intraarticular steroids, surgery last resort. The mallet finger is another sports injury, usually involving catching some sort of ball. A person has their hand extended and they reach out to catch a ball or to bat it away, and the ball strikes their hand rather than them hitting it with the part they want to hit it with, and they tear the extensor tendon. Well, if you tear your extensor tendon, what can you not do? You cannot extend the digit. So what happens is the person makes the fist, no problem. As they try to open it, the impacted finger doesn't go, can be moved passively into position, no problem. Make a fist again, try to open it. Finger stays stuck in flexion. The diagnosis is clinical, and the treatment is to the standard. Splinting and NSAIDs, intraarticular steroids, surgery. Trigger finger can be very easily confused for mallet finger. It is not a sports injury, but it has the same thing as cannot extend the digit. It is a stenosing tenosynovitis. Inflammation that compresses the tendon. They cannot extend. But when forced into extension, there's a pop, and that's the difference. Same thing, person cannot, when they open their hand, the finger stays in flexion. If they push it into extension, there's a popping sound. The diagnosis is clinical. The treatment is the standard. Splinting and NSAIDs, steroids, surgery. All right, moving away from the last four digits into thumb pain. This is de Quervain's tenosynovitis. Long name, simple disease. The patient is going to complain of thumb pain, but it's going to be one of two people. It's either going to be mom cradling baby, or it's going to be a guy lifting a bunch of weights, specifically in the over-the-head exercises where you have to push. It's a tendinitis. The diagnosis is made with a physical exam maneuver. The maneuver I've named fist, thumb, twist. The words you're looking for is ulnar deviation in pain. But the fist, thumb, twist measure is where you basically have them make a fist, put their thumb inside the fist. Don't ever make a fist like this if you're going to hit somebody. And then turn it towards the radius, no pain. Turn it towards the ulnar side, it stretches the tendon and it hurts. If you have that, the treatment is the standard. Splinting and NSAIDs, intraarticular steroids. Surgery here is not an option. Because it's an inflammatory disease, you don't want to go cutting it. Carpal tunnel is an inflammatory disease, but you cut the carpal tunnel, releasing the median nerve. These other are an injury to the tendon itself, so surgery can fix it. Two more to go. Dupuytren's contracture is a board favorite. We don't know what causes it, but we know it usually occurs in alcoholics and Scandinavian men. What happens is that the fascia balls up. So they have a contracture. Because they're contracted, they won't be able to extend their hand the whole way. But they're contracted because the fascia literally balls up and pulls the fingers together. So you're going to get the inability to extend, and you'll have palpable fascial nodules on the palm. And the hand will be in a contracture. The diagnosis is clinical. And having released the fascia, the hand goes back to normal. So surgical release works here. Here, NSAIDs aren't going to do anything because it's a fascial disease, not an inflammatory one. And lastly is the phelon. A phelon is just an abscess with a special name. It is by definition an abscess of the pulp of the finger. They will have an abscess. And so basically what happens is that the way the pulp works is that there's a mini compartment syndrome. So just a little bit of inflammation causes a lot of pain. So there's going to be a lot of pain, and because there's an abscess, there might be a fever and leukocytosis. This usually occurs as a product of penetrating injury. The diagnosis is clinical, and because it's an abscess, incision and drainage. Essentially, you're releasing the compartment syndrome by cutting into the fascial plane. It's like compartment syndrome on a very small scale. And because it's usually so small, just cutting it open and draining the pus is enough. Very rarely do you need antibiotics. Okay, in this lecture about ortho hand, what I want you to see is the standard. Most diseases of the hand are going to respond to splinting in NSAIDs, intra-articular steroids, and surgery. The ones where that's not true is going to be the Quervain tenosynovitis. Surgery isn't going to do anything. And the contracture, where surgery is the first step to release the fascial planes, as well as the phelon, where you incise and drain. Everything else follows the standard. If you're going to focus on anything, focus on carpal tunnel syndrome because it comes up on the test the most. That is ortho hand. Become a better doctor. Subscribe now to get access to our premium content.